Welcome to the deep dive. We're here to make complex medical topics, well, a bit less complex and hopefully pretty engaging.
That's the plan.
Today, we're tackling Unit 9 from Understanding Pathophysiology, 7th edition. It's all about the renal and urologic systems.
Yeah, the kidneys and everything downstream, absolutely vital stuff.
So our mission for you today is to really get a handle on how these systems are built, what they do, and crucially, what happens when things go wrong, like a roadmap through the unit.
Exactly, because, the kidneys are fundamental for keeping your internal environment stable. When they're off, it affects, well, pretty much everything.
Everything. Oh, look.
So we want to break down the what and the why it matters in a way that hopefully sticks.
All right, let's dive in. Segment 1, foundations, structure and function. So the kidney's main gig is keeping things stable inside, right? Balancing solutes, water, getting rid of waste.
Conserving nutrients, managing acid-base balance, it's a huge job.
And they're endocrine organs too. I find that fascinating, secreting renin for blood pressure.
Right. And erythropoietin EPO for red blood cells. Plus, activating vitamin D3 for calcium. They even release glucose if needed.
Wow, multitaskers like you said.
Absolutely. And all that boils down to making urine. 3 key steps: glomerular filtration, tubular reabsorption, and secretion.
Filter, reclaim, secrete. Got it.
And the bladder stores it, urethra lets it out. Simple in concept, incredibly complex in action.
Okay, let's picture the kidney itself. You've got 2 bean-shaped kind of tucked in the back.
Posterior abdominal cavity, yeah. Protected by fat and fascia.
And that entry point, the hilum, like a little docking station for vessels and the ureter.
Exactly. And if you slice it open, like in figure 31.2, you'd see the outer cortex and the inner medulla. The medulla's got these pyramid shapes.
Renal pyramids.
Right. And urine collects in minor, then major calyces, funneling into the renal pelvis, which is basically the top of the ureter. It's all very organized.
Okay, zooming way in now. The nephron.
Okay.
The workhorse unit. Like 1.2 million per kidney.
Roughly, yeah. Tiny factories. And if you look at figure 31.3, you see the parts. The renal corpuscle. Then this long winding tube, proximal tubule, loop of Henle, distal tubule, collecting duct.
And there are different types. Figure 31.4 shows superficial, mid-cortical, juxtamedullary.
Those juxtamedullary ones are key. Their loops dip way down into the medulla, which is crucial for concentrating urine. Really important for water balance.
Okay, let's talk filtration. The renal corpuscle. You described it as like a fist in dough, the glomerulus inside Bowman's capsule.
Yeah, that's a good visual. The glomerulus is this capillary tuft, and the filtering happens across the glomerular filtration membrane. Think figure 31.5, part B.
Right, 3 layers. Endothelium with pores, basement membrane, and those podocytes with filtration slits.
And importantly, it has negative charges. That helps keep big stuff like proteins and blood cells out of the filtrate. It's incredibly selective.
Smart design. And controlling it all, nearby, is the juxtaglomerular apparatus, or JGA. Figure 31.5, A shows it.
Exactly. You've got renin-releasing cells on the incoming arteriole and sodium-sensing cells in the distal tubule. It monitors and controls blood flow, filtration, and renin release. It's the control tower.
So the fluid gets filtered, then moves into the tubules. First stop, the proximal tubule.
Right. And this part, shown in figure 31.6, is amazing. It has this brush border, tons of microvilli.
Oh, yeah, for surface area.
Massive surface area. Reabsorbs like 60–70% of the filtered sodium and water, plus almost all the glucose, amino acids, other good stuff.
But it has limits, the transport maximum.
Exactly. If there's too much of something, like glucose and diabetes, the transporters get overwhelmed and the excess spills into the urine. That's why you see sugar in the urine with high blood sugar.
Makes sense. What about the rest of the tubule? Loop of Henle, distal tubule, collecting duct.
They do the fine-tuning, especially the loop of Henle, working with the surrounding blood vessels, the vasa recta, using this clever countercurrent exchange system. That's figure 31.13. It allows the kidney to make urine very concentrated or very dilute, depending on what the body needs.
And they make uromodulin here too, that protein.
Yeah, TAM horsefall protein. It helps protect against UTIs, binds to bacteria, and might play a role in preventing kidney stones.
Okay, quickly touching on the bigger structures, the ureter is just tubes, basically.
Long muscular tubes. They use peristalsis, wave-like contractions, to push urine down to the bladder. And yeah, pain from them can radiate quite a bit. Kidney stone pain is notoriously bad.
And the bladder, a muscular bag.
Pretty much. The detrusor muscle, lined with special uroepithelium. When it stretches enough, around 250–300 milliliters, stretch receptors fire off the micturition reflex.
The urge to go.
Right. It involves relaxing an internal sphincter automatically, but we have conscious control over the external one, usually.
Okay, crucial point. Regulating blood flow and filtration rate, the GFR. How does the kidney keep it steady?
Through autoregulation. Even if your systemic blood pressure swings between, say, 80 and 180 millimeter Hg, the kidney keeps GFR remarkably constant, around 120, 140 millimeter. Two main ways. A myogenic mechanism, where the afferent arteriole constricts if pressure rises, and tubular glomerular feedback, where those macula densa cells sense sodium in the distal tubule and signal back to adjust flow.
Clever internal controls. But nerves and hormones play a role too.
Definitely. Sympathetic nerves can constrict the afferent arterioles, reducing flow. And then there's the big one, the renin angiotensin aldosterone system, RAAS. Figure 31.9 outlines it.
Ah, yes, RAAS kicks in when pressure drops.
Exactly. It increases blood pressure systemically and helps the body hold on to sodium and water. It's counteracted by natriuretic peptides, ANP, BNP, urodalatin, which do the opposite, promoting salt and water excretion. It's a constant balancing act.
Okay, back to those kidney hormones, vitamin D.
The kidney performs the final activation step. So active vitamin D is crucial for calcium and phosphate absorption from your gut. If the kidneys fail, you get vitamin D deficiency, leading to bone problems.
And erythropoietin, EPO.
Produced by kidney cells when they sense low oxygen. EPO travels to the bone marrow and says, make more red blood cells.
Which explains the anemia in chronic kidney failure.
Precisely. Lack of EPO is a major cause. EPO also seems to have other protective effects, which is interesting.
So how do we measure how well all this is working? Tests.
Key test is estimating GFR. We often use creatinine clearance. Creatinine is a waste product, and how well the kidneys clear it from the blood gives us a good GFR estimate.
And higher plasma creatinine means lower GFR?
Generally, yes. It's an inverse relationship. We also look at blood urea nitrogen, BUN, another waste product, and of course, urinalysis checking the urine's appearance, pH, concentration, and looking for cells, protein, glucose crystals. Table 31.1 lists common findings and what they might mean.
And function changes with age.
It does. Infants have immature kidneys, lower GFR, can't concentrate urine well. Older adults tend to lose nephrons, GFR declines, and concentrating ability diminishes, makes them more vulnerable to dehydration or fluid overload.
Okay, that sets the stage perfectly. Now let's talk about when things go wrong. Segment 2, alterations, starting with obstructions.
Yeah, urinary tract obstruction. Basically, a blockage anywhere from the kidneys down to the urethra.
And that causes backup.
Exactly. Urine backs up, dilating the structures above the blockage. If it's the ureter, that's hydroureter. If it reaches the kidney's collecting system, hydronephrosis, you can picture that dilation in figure 32.1b. This backup increases pressure, hampers GFR, invites infection, and can cause permanent damage like tubulo-interstitial fibrosis over time.
Scarring again. Does the other kidney pick up the slack?
It tries. Compensatory hypertrophy and hyperfunction.
Mm-hmm.
But it puts strain on the remaining kidney. And interestingly, after you relieve a significant obstruction, patients can have post-obstructive diuresis, massive urine output, needs careful watching for dehydration.
Okay, a super common obstruction. Kidney stones. Nephrolithiasis.
Very common.
Mm-hmm.
And unfortunately, they tend to recur. Most are calcium oxalate or phosphate.
How do they form?
It's usually a combo of things. Urine gets super saturated with stone-forming salts. They precipitate out as crystals. These crystals grow. And maybe there's a lack of natural stone inhibitors like that uromodulin protein. Urine pH is also key. Alkaline. Urine favors calcium stones. Acidic urine favors uric acid stones.
And the pain. Renal colic.
Agonizing. Typically starts in the flank, comes in waves, radiates down towards the groin, often with nausea, vomiting, maybe blood in the urine.
Treatment.
Manage the pain, push fluids to help pass it, sometimes meds to change urine pH. Diet changes can help prevent recurrence. Less oxalate, maybe less animal protein, limit sodium. If it won't pass, procedures like lithotripsy use shock waves to break it up.
Okay, what about blockages lower down,
Yeah.
LUT obstruction?
Right, affecting storage or emptying.
Mm-hmm.
Think urethral strictures, enlarged prostate in men, pelvic organ prolapse in women where the bladder might sag, a cystoscopy.
And the bladder reacts.
Over time, the detrusor muscle has to work harder. It can get thickened, trabeculated, less compliant, leading to incomplete emptying, urine retention.
Then there's overactive bladder, OAB, urgency, frequency.
Yeah, that sudden gotta go now feeling, often frequent trips, nighttime voiding, but without an infection, often due to involuntary detrusor contractions.
And neurogenic bladder, nerve issues.
Exactly. Neurologic problems affecting bladder control. You can get detrusor hyperreflexia, an overactive spastic bladder, or detrusor reflexia, a flaccid, underactive bladder that doesn't empty well.
Yeah.
Depends on where the nerve damage is.
Tumors are another issue. Kidney cancer.
Mostly renal cell carcinoma, RCC. More common in older men, linked to smoking, obesity, hypertension, often silent early on. The classic triad hematuria, flank pain, palpable mass, usually means it's quite advanced.
And bladder cancer?
Usually transitional cell carcinoma. Again, older men, smoking, chemical exposure are big risk factors. The hallmark symptom, painless hematuria. Blood in the urine without pain should always be checked out.
Okay. Infections, UTIs.
Very common, especially in women. Usually bacteria from the gut, like E. coli, traveling up the urethra. Things like anatomy, incomplete emptying, or catheterization can increase risk.
So cystitis is the bladder infection. Frequency, urgency, pain.
Yep, classic symptoms. Though in older adults, confusion might be the main sign. Then there's interstitial cystitis, or painful bladder syndrome, chronic pain without infection, maybe autoimmune.
And pyelonephritis, kidney infection.
More serious, infection reaches the upper tract, the kidney itself, often follows obstruction or reflux. Symptoms are more systemic: fever, chills, flank pain, maybe white blood cell casts in the urine. Chronic pyelonephritis involves persistent infection, scarring, and can lead to kidney failure.
Let's shift to the filters themselves. Glomerular disorders, glomerulonephritis.
Inflammation of the glomeruli, often immune-mediated. Think of antigen-antibody complexes getting trapped in the glomerulus, like in figure 32.5, causing damage.
Makes the filter leaky.
Exactly. Increased permeability, so protein and red blood cells leak into the urine. GFR often decreases too. There are many types like post-strep glomerulonephritis, diabetic nephropathy.
Diabetic nephropathy, you said that's the biggest cause of CKD.
By far. High blood sugar over time damages those delicate glomerular capillaries. Lupus can also cause lupus nephritis.
And this damage leads to syndromes, nephrotic versus nephritic.
Right, they're patterns of glomerular injury. Nephrotic syndrome is the big one for protein loss, excreting over 3.5 grams a day. This causes low albumin in the blood, high lipids, and major edema. That fluid shift we talked about, that's figure 32.7, showing that generalized swelling.
Okay, massive protein loss is nephrotic. What's nephritic?
Nephritic syndrome's hallmark is hematuria blood in the urine, often with red blood cell casts visible under a microscope. Proteinuria is usually less severe than a nephrotic syndrome. Table 32.7 compares them nicely. Both increase risks like infection and blood clots.
Okay, moving to acute sudden problems. Acute kidney injury, AKI. What is it exactly? How's it different from kidney failure?
AKI is a sudden decline in function. Decreased GFR, maybe low urine output, waste products like creatinine and BUN build up quickly. Kidney failure is more the end-stage outcome. AKI is classified using criteria like rifle risk, injury, failure, loss. ESKD, end-stage kidney disease, shown in Table 32.8, indicating severity.
What causes AKI?
Three main categories. Perrenal is most common, not enough blood flow to the kidneys. Think dehydration, severe blood loss, heart failure, sepsis. Then intrarenal AKI is direct damage within the kidney tissue itself. Often acute tubular necrosis, ATN, caused by ischemia, lack of oxygen, or nephrotoxins like certain drugs or contrast dye. Figure 32.8 shows how this can lead to oliguria, low urine output, and postrenal AKI is an obstruction after the kidney, blocking urine outflow. Like kidney stones blocking both ureters or an enlarged prostate clamping down on the urethra. Has to affect both kidneys usually, or a single kidney if that's all the person has.
And AKI has phases.
Typically, an initiation phase where the injury occurs, a maintenance phase, often with low urine output, oliguria, or waste products accumulate, and then hopefully a recovery phase where urine output returns, often excessively at first, polyuria, risking fluid and electrolyte problems.
All right, last major area of alterations, chronic kidney disease, CKD.
CKD is a progressive, irreversible loss of kidney function over at least 3 months, often linked to those big systemic diseases. Diabetes is number 1, hypertension is number 2. Table 32.11 shows the stages, based on GFR.
How does it progress?
Initially, the remaining healthy nephrons compensate. They hypertrophy and work harder the intact nephron hypothesis. But this extra workload eventually damages them too. Key drivers of progression, shown in figure 32.9, are things like ongoing proteinuria and the activity of angiotensin II, which promote inflammation and fibrosis, that scarring process again.
And the effects are body-wide.
Absolutely. Table 32.13 lists them. It's extensive. Fluid and electrolyte chaos, high potassium, metabolic acidosis, bone disease, renal osteodystrophy, huge cardiovascular risk, anemia from low EPO, weakened immune system, neurologic issues like uremic encephalopathy, endocrine problems, reproductive issues. It touches everything.
Wow. Okay. Huge impact. Let's pivot now to our youngest patients. Segment 3, children. Because things often present differently, right? Starting with congenital issues, kick up.
Right. Congenital anomalies of the kidney and urinary tract. These account for a huge chunk of pediatric kidney failure. You can see various structural issues in figure 33.1, kidneys in the wrong place, ectopic, fused together, horseshoe, one missing aplasia, underdeveloped hypoplasia, or formed abnormally dysplasia.
What about polycystic kidney disease, PKD?
Inherited. Multiple cyst form. There's an autosomal dominant form, ADPKD, usually shows up later in life, and a rarer autosomal recessive form, ARPKD, often detected before birth or in infancy, much more severe usually.
Renal agenesis, missing kidneys.
If it's unilateral, just one missing, the other kidney usually compensates, but it's at higher risk long term. Bilateral agenesis, missing both, is fatal, often associated with Potter syndrome and distinct facial features.
Other blockages.
Uretropelvic junction, UPJ obstruction, is the most common cause of kidney swelling, hydronephrosis in newborns. It's a blockage right where the ureter leaves the kidney.
And issues with the urethra or bladder structure, hypospadias.
Yep, figure 33.2 and 33.3 show hypospadias. The urethral opening is on the ventral or underside of the penis. Sometimes there's chordee, a downward curve. Epispadias is rarer, opening on the dorsal side. And the most severe is bladder exstrophy, figure 33.4, where the bladder is basically open and exposed on the abdominal wall. Needs urgent surgery.
Moving to acquired conditions in kids, glomerulonephritis.
Acute post-streptococcal glomerulonephritis, PSGN, is classic in kids. Happens after a strep throat or skin infection. Sudden onset hematuria, proteinuria, edema, high blood pressure. IgA nephropathy is another common one, often causing visible blood in urine during respiratory infections.
And nephrotic syndrome in kids.
More common than in adults, usually minimal change nephropathy, MCN. We think the podocytes, those filter cells, lose their negative charge and their little foot processes fuse together. This causes massive albumin loss.
So kids get that swelling too.
Oh yeah. Figure 33.5 shows it often starts around the eyes, then becomes more generalized, sites in the belly, swollen legs. Urine looks frothy from all the protein, but also very prone to infections.
What about hemolytic uremic syndrome, HUS?
That's the most common cause of acute kidney failure in young children. Usually follows infection with Shiga toxin-producing E. coli, often from contaminated food. It causes a triad: hemolytic anemia, low platelets, and acute renal failure. Very serious.
And Wilms tumor.
A rare kidney cancer, but one of the more common solid tumors in young kids, usually under 5. Typically presents as a painless abdominal mass found by a parent or doctor. Survival rates are thankfully quite high with treatment.
Okay, last bit for kids, UTIs and incontinence.
Pediatric UTIs are tricky. In infants, especially uncircumcised boys or those with congenital issues, risk is higher. Symptoms can be vague fever, irritability, poor feeding. Older girls get them more often. Need a urine culture to confirm vesicorital reflux, VUR, is a big factor.
DUR, that's urine flowing backward.
Exactly. From the bladder up towards the kidneys. Figure 33.6 and 33.7 show how a short tunnel where the ureter enters the bladder allows this reflux. It sets kids up for recurrent kidney infections, pyelonephritis, which can cause scarring and long-term damage, even CKD. It's graded by severity, sometimes resolves on its own, sometimes needs surgery.
And incompetence, wetting.
Beyond the age, kids are typically toilet trained. Can be daytime incontinence or enuresis, nighttime wetting. Lots of potential causes: UTIs, constipation, neurologic issues, sometimes just maturational delay or genetics. Need to rule out underlying problems. Treatment often involves behavioral strategies first.
It really brings it all together, doesn't it? Seeing how those basic structures and functions from Chapter 31 play out in all these conditions and how they look different across the lifespan.
Absolutely. That foundational knowledge of filtration, reabsorption, hormonal control, it's the key to understanding why an obstruction causes hydronephrosis, why diabetes leads to nephropathy, why a child with VUR gets recurrent infections. It connects the dots.
This deep dive really traced that path from the kidney's elegant design for balance through the many ways things get disrupted, right up to the specific challenges in children.
And understanding these pathways is just so vital, whether you're learning this for exams, applying it in clinical practice, or just fascinated by how the body works. Knowing the pathophysiology links the symptoms to the why.
Totally agree. So here's a final thought to leave you with. The kidney is incredibly adaptive, but chronic disease is still a huge challenge. Thinking about its role in so many body systems, how might future therapies, maybe ones that tap into the kidney's own potential for repair or regeneration, change the game for managing CKD down the road?
A hopeful thought to ponder.
Definitely. A huge thank you from the Deep Dive and all of us at the Last Minute Lecture team for joining us today.
Thanks for listening.
Until next time, keep that curiosity flowing.